Good evening, everyone, and thank you for joining us for this session today. This is the culmination of a series of events that happened over the last 1 month. And as you're aware, March is considered the Endometriosis Month. And we started this journey about a year back. And when we did a, sort of a opportunity scan, because we work with several patient groups, we found that there is not much work done around women's health in the context of India, except for, of course, maternal and child health. Whereas when I attended patient conferences in other countries, I found there was a strong movement around endometriosis, PCOS, and other conditions that are related to women's health. So obesity and diabetes, for example, in women, teenage obesity, all those things were being discussed quite openly, but nothing in the context of India. And therefore, we decided to start this journey and see, whether patients and caregivers and people who had endometriosis were willing to come together to speak about their condition and be open about it. And we conducted a series of focus group discussions, 16 in total, in fact. And these focus group discussions threw fantastic insights. So the women were from across the country, from rural and urban settings, from various regions, and each one had their own unique problem or story to share with us. So what we did was, this was such rich data that we collected that and we composed it into something called patient journey mapping. So we have 3 sets of patient journeys for different stages of women from different experiences. We also came together with this whole idea. In fact, the patients in our group suggested that just discussing amongst ourselves is not enough, and we should go wider and be able to discuss this in a bigger platform. And why don't we do something except having webinars? So we then designed something called the Endo Run, and we planned it for 5 cities, and we already completed it in Delhi and Pune. We are now going to have it over the next week in Hyderabad and Kolkata, and then we'll finally culminate it in Mumbai. The original plan was to have everything within March, but because of school exams and university exams, we had to sort of stagger it a little bit. And the idea was to have this expert session as the finale to those 5 events that we had. But our planning went a little bit awry because of exams. So we are having it sort of in the middle of the events. And I think it's very good because all the people who will join this session today will be able to learn from the experts on what kind of challenges of diagnosis and treatment we have for endometriosis in the context of our country. I have got 5 excellent speakers who have joined us today from different parts of the country, and they will be bringing very unique perspectives about the condition, as well as what kind of challenges are there when, as caregivers and providers, they face the challenge themselves within their homes, as well as healthcare providers and diagnostics, etc., when they are working out of hospital systems and patients come to them. So I've already introduced myself. I'm Dr. Ratna. Our first speaker for the day is Dr. Narendra. Can I have the next slide? Dr. Narendra Malhotra. I cannot see this slide, so let me just read from mine. So Dr. Narendra Malhotra is the Managing Director, Global Rainbow Healthcare, Ujjwala Cygnus Rainbow Hospital. He's also the Director of ART at Rainbow IVF and several director positions. He's a National Director, Ian Donald School of US Ultrasound, Professor of Sarajevo School of Science and Technology, Croatia, Professor in International University, Croatia, past Vice President in several societies. And he's also the founder editor of a journal and the member of the FIGO Guidelines Committee. FIGO is the International Committee for Obstetricians and Gynecologists, not a committee, a society. And he's also the chairman of Smriti, an NGO, which looks at new level of care. The speaker who follows him is Dr. Nitin Chaubal, and he again comes with several accolades to his name. His present attachments are he's a consultant in ultrasound, Jaslok Hospital and Research Center, Mumbai, and he's the director, Thane Ultrasound Center, Thane, and a professor emeritus at D.Y. Patil University, Navi Mumbai. He has immense teaching experience as a visiting faculty at St. G.S. Medical College and is presently a teacher for postgraduate radiology students. And he has conducted innumerable workshops in ultrasound and color Doppler. Following him, we have a speaker, Dr. Meenakshi Ahuja, who recently was there with us in one of our events in New Delhi for the Endo Run. She's a gynecologist and obstetrician at Fortis La Femme and has several years of more than 2+ decades of experience. She's well known by her patients as a competent and compassionate doctor, and we saw this in person when she was addressing students at IHMR New Delhi. She's chaired several sessions in various gynecological forums and has an impeccable reputation and is well renowned in local and international circuits. And she's been practicing obstetrics and gynecology in private hospitals and nursing homes in South Delhi, including Fortis, Mass, Spring Meadows, and Modi hospitals. We have a very distinguished speaker following Dr. Meenakshi, and he's Peter Said. He's a registered nurse and an MPH and head of patient engagement APAC at Bayer Pharmaceuticals, and he will be speaking to us through a recorded message. And our most important speaker of the day is Dr. Radhika Javeri. She's an endometriosis patient and patient advocate, and also a holistic nutritionist, women's health coach, founder of Pain Free Endo System. She has addressed several of our patients in our expert sessions. She's internationally certified endometriosis coach and endo warrior since the age of 13 and helps endo warriors to live pain-free by managing their symptoms with a holistic approach. She believes in adding menstrual hygiene and hygiene for girls in education system and loves reading, dancing, and traveling the world. So welcome to all the panelists. It's a great pleasure to have you with us today. And we will start with our first panelist, who is Dr. Narendra Malhotra, to be speaking to us about his topic for today. So over to you, Dr. Malhotra.
A very good evening to all of you. It's indeed a great pleasure to be here on and addressing all of you on a topic which is very, very dear to us here. And just a second, I can't get this screen. Endometriosis. And endometriosis is something which it's a very debilitating disease and a debilitating disease. So what has changed was something which I'm going to talk about, and some gold standards for treatment and current options in India, including some financial support groups. And me and my wife, Dr. Jaideep, who is a co-director with me, bring you these presentations. So endometriosis is an enigma. It's a very complex and elusive and challenging disease. I call it benign cancer because it is cancer and it is not, it is benign, but it is not cancer, but it spreads. And as the month of March, we all experts are trying to share what this disease and how it affects women. So women face with endometriosis, come to us with infertility, chronic pelvic pain, nausea, abdominal bloating, fatigue, depression, anxiety, among others, many other common symptoms associated with our disease. Let's see how this endometriosis places high burden on the society. So the high burden is placed by individual impact, by delay in diagnosis, and by societal impact. And that is because there is increased risk when the girls have early puberty. Dysmenorrhea and pain causes loss of hours, and dyspareunia, comorbidities, dysmenorrhea, fitness, infertility problems. Then majorly it affects or impacts on the sexual life and on the academic professional performances and the impact on personal relationships. And the healthcare cost, utilization, unemployment, abstinence, negative impact on goal attainment, reduced work productivity is all a societal impact. So when we look at all these, severity of the symptoms, some people say we don't know how severe it is. Some people are not affected, mildly affected about 16%, mainly sexual life, moderately affected about 26%, and severely negatively affected are about 25%. And this is sexual life, relationships, housekeeping, all the activities which I just told you. So it is a disease which is not only a medical disease, it has a social impact also. So the negative impact also is seen on ovarian reserve. When we have big endometriomas, ovarian endometriosis, the ovarian reserve goes down and infertility comes to them early in life, and if not handled. When we look at this article, it says endometriosis is a chronic gynecological condition which has been referred to as a missed disease. No, we are not, because people were not clear, and even healthcare providers and doctors are not clear about it. And it has been largely ignored by the government policy in research funding, despite of having such a major impact on the society and on the work. So what happens is that to explain pain, we have to provide validation, to reduce the feelings of isolation, and then to provide an early treatment so that to impact the natural history, so to reduce the chronic pain, reduce the pain syndromes, and reduce the risk of infertility. So we need to go step by step like this. And what people don't let go step by step is that women wait for almost 3 years before they start seeking medical attention for pelvic pain. And then the physician has a knowledge gap. And there's a physician resistant to learn about any pain in abdomen is intestinal, appendicitis, chronic PID, pelvic congestion syndrome. So those vague terms are given to this disease. And of course, when it comes in adolescent, it is a patient knowledge gap and the patient normalization. So the frequent misdiagnosis is chronic pelvic pain, bleeding disorder, irritable bowel or colon, food intolerance, psychosexual complaints, overactive bladder, PID, appendicitis. And see, in this circle, nobody is thinking of endometriosis. That is what we got to change the attitude of think endometriosis. So the delayed referral from a GP to a gynec consultation takes about 3 years. 30% have had more than six primary care treatments before they come to a diagnosis. 49% have had more than 2 secondary level referrals. 2 gynecologists seen them, and then they come to a diagnosis. And most of them have been given 3 different types of COCs, and the pain is still persisting. So the interventions to reduce the diagnostic delay, we have to improve knowledge. We have to stress on faster referral to gynecs. We have to improve the quality of physical examination. Patient have to give time. So we need to have chronic pelvic pain clinics or endometriosis clinics. And it needs a multidisciplinary team. We all know that. And you have to reduce the waiting list for an ultrasound, for an MRI. In an NI scheme, it probably takes months before they get an appointment for that. We have to improve the knowledge of the menstrual physiology, pathology, and endometriosis to the GPs and even to the specialist. And of course, for fertility, they have to be an early referral to the infertility specialist. So the protocol for early diagnosis would be if the patient comes with pain, gynecological symptoms, non-gynecological symptoms, or adolescent not responding to NSAIDs. And if the answer to all these is yes, then they need to have a pelvic exam, either PV or rectal if they don't allow that. And if there is a painful nodule in the tenderness, you start suspecting deep endometriosis. If there is a visible vaginal lesion nodule, start suspecting. If there is an adnexal mass, endometriomas. Or if there is a uterine enlargement, adenomyosis. So clinical diagnosis will be made on a thorough clinical examination, and then they go for imaging, which will be discussed. So history, physical examination, clinical diagnosis, or suspected diagnosis, then imaging, and then we start thinking of any interventional procedures like laparoscopy and all. So why endometriosis specific imaging is important? Because we want to diagnose it, we want to map the disease, we want to assess the severity, and we have to provide a triage of care. So this will be discussed. Now, there are many classifications which were made: mild, moderate, severe endometriosis. Then came the American Society Reproductive Classification, but these are all complex. Then came the NZN classification, and then, of course, we had the IDEA group giving us a AMOS classification. AMOS means adenomyosis, EMOS means endometriosis. So for here, you had to go stepwise. 4 steps: evaluate the uterus adnexa, evaluate transvaginally by soft markers, do the sliding sign by ultrasound, and then assess the deep endometriotic nodules in the anterior and posterior compartments and give them a score. And you see, this was simpler, and all gynecologists who are well versed with ultrasound, or not even well versed, average with transvaginal pelvic ultrasound, can do this. And that has to be taught to all of them. Then, of course, for fertility, we need to do fertility prediction. So we have Adamson's score, and again, a very simple score, 10-point assessment. Only 2 points are directly related to endometriosis. The others, and if EFI is not a classification of endometriosis. It will just predict that what they need for fertility treatment, whether they need to wait, whether they need ovulation induction, whether they need IUI, or whether they need to go straight away for IVF. So that is it. Then what is important is that we want to have valid guidelines. And these valid guidelines, if they are there, should be circulated well. So we had valid guidelines by ESHRE. ESHRE endometriosis guidelines is very, very good guidelines. And 2012, 2014, and now we have the comprehensive new ESHRE guidelines of 2022 with 109 recommendations on diagnosis, treatment, and all. And this should be simplified document, should be circulated to all the gynecologists, especially in the 2nd and the 2-tier and the 3-tier cities where they are not so academically going to conferences. So there have been some changes in the guidelines. The first change was that you don't need laparoscopy as a gold standard. And chapter-wise, all these changes occur. So laparoscopy is no longer a diagnostic gold standard. You can diagnose by ultrasound and not need diagnosis. Then you can diagnose by clinical symptoms, which is the first step: dysmenorrhea, dyspareunia, dysuria, dyspepsia, painful rectal bleeding, hematuria, shoulder pain, pneumothorax. All these should give you an indication there's endometriosis. And then make a diagnostic algorithm. So go follow the diagnostic algorithm given by the guidelines. We can discuss this later. Depending on that, you classify the patient. She is adolescent, she's in reproductive age group, she's in perimenopausal age. If she's in reproductive age group, whether she wants fertility or not fertility. If she's having infertility, so the treatment. And whether her treatment complaint is pain or infertility or the others. So we will start the treatment with analgesics, we'll start the treatment with combined OCPs, we'll start the treatment with only progesterone, GnRH antagonist, agonist, aromatase inhibitors, and if still not relieved, or if it's a big lesion, then surgical treatment. So surgical treatment is not the first line again, and it is recommended to offer surgery as one of the options to reduce endometriosis-associated pain and infertility. So surgery, what we used to do when we were taught in 2012, that do surgery first. Of course, if you have endometriomas this big on ultrasound, and she's infertile, or she's having severe pain, she will have severe pain. This needs to be surgically done. Complete surgical treatment is hysterectomy for perimenopausal or menopausal women, but sometimes even that, the pain recurs because it's in the peritoneum, or it's in the bowel, or it's in extraperitoneum. So there is a strong recommendation to add medical therapy as adjuvant to surgery. There is a moderate recommendation to add comparing the medical and surgical treatments, and to do some non-medical management strategies, psychologically, Chinese medicine, acupuncture, acupressure, nutrition, yoga, electrotherapy, physiotherapy. All that can be added to increase the general well-being of the patient. So if the complaint is pain, painkillers, hormone, surgery, that's how we go. If it is infertility and the tubes are patent and the sliding sign is negative and there are no mass lesions, adnexal lesion, medical assisted reproduction, mild ovulation induction with IUI. And if there are grade 3 or grade 4 endometriosis, then we'll do the EFI or the prediction Adamson score, and depending on that, take them for IVF or ART. If there is mild dot-like lesions here, the new guidelines say that you need not treat them. But supposing you're doing a laparoscopy for unexplained infertility and you run into them, then we tend to fulgurate them so that they don't grow into bigger lesions. Of course, if there are lesions like this, which are big bilateral endometrioma, kissing ovaries with an omentum stuck in between them, then depending on the pain and the age and previous surgeries, we go ahead and manage them surgically or non-surgically. Now, if this patient has had 2-3 surgeries and this has recurred, then there is a place for just drainage and stimulating them, collecting as many oocytes as possible. So oocyte pooling and then doing IVF or ART. So ART can be performed for infertility associated endometriosis, especially when it is compromised, the tubal factor is compromised, the male factor is there, and there is a low EFI score, Adamson score, and all other treatments have failed. And it is a grade 3, grade 4 endometriosis. So that, and this is one of the things which we do before actually going in for ART. If there is still a cyst, we try to drain them and inject some sclerosing agent, and this works. Of course, sterile, you have to be very sure that you're doing it in a sterile atmosphere and doing the right way. Now, the non-medical management for infertility is mild endometriosis, wait. Sometimes they say back massage also starts ovulation induction. So you can try that if the patient is young and she's not severely affected by this disease. If she's severely affected by the disease, then we can start thinking of fertility preservation. If there are big endometriomas, grade 3, grade 4, she's an unmarried girl, collect all her oocytes, do oocyte preservation in 2 or 3, and then go ahead and do the surgery. Because later, if their AMH falls and their ovarian reserve decreases, then you might not get oocytes later on in life. So there is a role of fertility preservation also. Then patients are recommended to get pregnant early if they have the disease. If they're found in teenage, we tell them get married early and get, though pregnancy is not a treatment, but it suppresses the disease. And sometimes the endometriosis changes in disease because of the progesterone receptor. And that's a long story, and that can be discussed sometimes later. And then you have to be aware, clinicians, that there's an increased risk of first trimester miscarriage and ectopic pregnancies with endometriosis. So we need to be careful. So infertility, different options, hormonal treatment for suppression not required, surgery or medically assisted reproduction. Spontaneous conception can be tried if the EFI score is good. Otherwise, you go straight away to ART. Now, then we have what is recurrent endometriosis. Now, this is the dreadful condition because this disease is going to recur. Even with the best of surgeons, it's going to recur. Whether it's coming in 1 year, 2 years, 5 years, then repeated surgeries are not recommended. And there is where drainage. And if she's in fertility, tell them to get pregnant. If it is recurring too many times, then maybe a major operation. Here where we can try LNG, IUCD to suppress progesteronal effect on the uterus, especially if it is adenomyosis and even in endometriosis. So recurrent endometriosis, hormone treatment is better than surgeries because repeated surgeries are not recommended. In adolescent, again, endometriosis is there and should not be ignored. Pelvic pain should not be ignored at dysmenorrhea. Complete imaging study and complete suppression by medical treatment, or if the disease is bad, maybe surgical treatment should be resorted to. So adolescent diagnosis is very, very important. Sometimes transvaginal ultrasound may not be allowable because of virginity. Then MRI, transabdominal, transperineal, transrectal ultrasound should be done. CA-125 as a biomarker for diagnosis is not required, maybe for follow-up and first line of treatment, again, NSAIDs and hormones, COCs, or suppression by laparoscopy when the disease is bad. Even in adolescent, we will. Postmenopausal, again, or premenopausal or menopausal, if the disease is bad, then a hysterectomy would be better treatment because we don't want the disease to come back with minor treatments. Sometimes there are extra pelvic, it may be in the bladder, it may be in the bowel, it has been seen in the diaphragm, it's almost been seen in the nose, scar tissue, wherever it is, the nodule has to be recessed after trying to suppress it by medical treatment, dynogist. Asymptomatic and endometrioma, then we do not routinely do surgeries for asymptomatic. If it is a silently lying, she's getting pregnant on her own, she's having no pain, the disease is not progressing, follow it up and you can carry. Endometriosis pregnancy is a different topic and maybe sometimes it's going to increase. Sometimes when you do a cesarean section, doctors, when you look at behind the uterus, you see lots of bleb lesions. That is endometriosis and that's not chlamydia. How do we prevent this disease? Healthy lifestyle, diet, reduce alcohol intake, and regular physical activities is the one. Of course, immunity is there. Women have to be strong in immunity so that they can remove all the menstrual blood which goes into the pen. Endometriosis cancer, higher risk of ovarian, breast, thyroid cancer. The increase in absolute risk compared with general population is low. So no need to worry too much, but you need to have a healthy lifestyle. So avoid smoking, maintain a healthy weight, exercise regularly, avoid alcohol or very low alcohol intake, have a lot of fruits and vegetables, and a sun protection, vitamin D. So cancer prevention is there. Now, to the last few messages and slides, it is undervalued, this disease. So we need to have funding and a call of action. Now, research funding for endometriosis is limited. And it has been seen not even in USA, there has been a good budget. The most developed countries also don't have a big budget for this disease. In USA alone, and the worldwide 6.5 million in USA and worldwide 190 million women suffering from this disease. So we need to have some research going into it. And because this is a disease which is affecting jobs, families, society. So it is a societal problem. It is a government problem. It is a national problem. So it should be taken up in the national agenda. The disease is substantial. So we need to have a correct amount of funding so that we can go ahead and treat the disease. How much funding endometriosis get? We see in USA from $7 million, which is peanuts, to $6 million back again. And India, we don't have any government funding for this disease. Maybe some NGOs and all are working on it, but we still need to have a government program for endometriosis. How much the treatment cost? A treatment can cost anything from 60,000 to 80,000, even much more if surgeries are required at a very good center of sometimes robotic surgeries and all are done. Because the drugs are expensive. GnRH analogs are expensive. Endogest, the best quality ones, is expensive. And grade 3, grade 4 endometriosis will need IVF, which is also expensive because of the reason. Does insurance cover the treatment? Yes, it covers the treatment for if it is endometriosis. But if it's infertility related endometriosis, then sometimes you don't have to write infertility. Some insurance companies are now keeping infertility also in there or IVF also in there. But then you have to have a lag period. So no, you cannot insure today and report the disease tomorrow. So maybe 3 or 4 years later, they might cover for infertility treatment also. So that also needs to be changed. Then, of course, we have the Endometriosis Foundation of India, which is doing all this. More than 25 million estimated suffering women from India out of the 190 million worldwide. So India has a chunk of it. We thought this was not an Indian disease. It was only a stress-related disease somewhere south India. It's not there. It is equally for everyone. And then we have some endo crusaders, and we have Dr. Vimi Bindra, who's unfortunately not joining us today because of family issues, but they are working and many other people are working on this. So, ladies and gentlemen, to conclude, endometriosis is an elusive disease. According to me, it is like a benign cancer. There is no awareness amongst GPs and a lot of gynecologists, and they just give painkillers, and pain should not be ignored. And then we should force the government to have some endometriosis funds or endometriosis. Thank you very much. I bring you greetings from our city, Taj Mahal, and from our center and from our training academy, which we run in Agra. Thank you very much for inviting me to be a part of this great awareness activity which we are doing.
Thank you. Thank you for that very enriching discussion on gold standards. And I discovered that apart from the research, much of those gold standards are also not practiced, either because physicians are unaware or because patients are unable to pay for it, considering our healthcare system where patients have to pay out of pocket. I wasn't going to ask any questions, but just one comment, Dr. Malhotra. ICMR has just announced a whole battery of invitations for research proposals. And after you pointed out, I discovered that there is nothing on endometriosis or PCOS. So maybe there needs to be some advocacy at the research institution level to see how we can include topics such as this, because they are giving a lot of funds. The cap is for implementation research, the cap is 1.5 crores, which is a substantial amount for small field-based studies on at least the perceptions around endometriosis and patient, stories, etc. So how can, advocates like perhaps yourself or the Obstetrician Association, FOGSI, help this happen so that there is more focus on research?
So we at FOGSI have an endometriosis committee, and we do our own surveys and of the doctors and awareness programs and everything. Now, we need to put a proposal of a research proposal to ICMR. Maybe we can put it through FOGSI, we can put it through the imaging department, the INSWOG with Dr. Nitin Chaubal and ourselves. We can put it through the Endometriosis Foundation. Here, hey, look, we need to do, number one, a survey to get an actual picture of endometriosis and how it is being managed in India. Then we need to do the drugs which are effective, and we need to have our own Indian guidelines. So we can refer to the ESHRE guidelines, have a working group, and make an ICMR related or an endometriosis foundation related simpler guidelines and circulate them widely to 40,000 gynecologists. 40,000 official FOGSI members, but I believe there are 1 lakh gynecologists in India. So we need to do something. Yes, let's put a proposal to ICMR. They will be forced to look at it and maybe ask us that what do you need?
Yes, sir. Thank you so much.
So there
one
are
of the
two
things
questions. I see
Yes.
2 questions. I can answer them live. Hi, is endometriosis a uterine disease or an endometrial tissue and affected by the uterus preservation? So endometriosis is a disease where the endometrial tissue goes and implants either inside the uterus, that is known as adenomyosis or AMOS, which Nitin will tell you how to diagnose. And if it goes out through the tube in the peritoneum, which it goes out every menstrual period, and it is phagocytosed by the immune system of the woman. So if the immune system is weak, Samson's theory is still, we say it goes back, and then it will cause irritation, inflammation, cytokines, adhesions, neovascularization, and then the cyst and wall form. So your second hormone is, how is it related to ovarian hormones? Well, it's endometrial tissue. It is an ectopic endometrial tissue, but it is going to respond to estrogen and progesterone. So when a disease responds to estrogen and progesterone, the treatment with COCs, aromatase inhibitors will work. So that treatment, and we need to validate which treatment in what doses will work. So that is the kind of research we need. Thank you very much for asking these questions.
Thank you, sir. And we thank you for those enlightening remarks as well as answering the questions. And as you mentioned, there is a diagnostic as well as a treatment delay of 7 to 10 years, of which the diagnostic part of it is a very big challenge, even with very experienced gynecologists. So I'd like to invite Dr. Nitin Chaubal to enlighten us about the challenges of a diagnosis and what are the advances that are happening in this field.
Yeah, hi. I hope you can hear me and see my screen.
Yes, we can hear you,
great,
see
great.
you.
Hi,
Welcome, Nitin, to
Narendra.
this.
So it's always nice to meet Narendra on such platforms. We are very close friends for years. And he's a very strong orator and he's given very strong messages, which are going to be useful to, of course, everyone. So my part is to talk on the role of imaging techniques, because these are very important as far as diagnoses are concerned. And we already said that the overall, we have a lot of challenges when it comes to diagnosis of endometriosis, not only clinically, not only biochemically, but also on imaging. And we'll just see how imaging helps us in our practice. We already aware of the extent of the disease, the number of women affected in the reproductive age group, a common cause of infertility, a common cause of chronic pelvic pain, as we know. And these signs and symptoms largely would depend upon where is the endometriosis and whether it's involving the surrounding organs. Signs could be right from menstrual cramps to pelvic pain to painful intercourse, to urinary problems or GI problems, and of course, infertility. And not only that, this affects the social life of a lady. It affects the productivity in terms of work. It can affect psychological aspects. It can affect relationship. So it's an overall not only a disease which affects the uterus, ovaries, or sometimes the deep pelvic organs, but it affects the entire life of the lady, her family, and of course social well-being as well. So it's a major problem, as you're all aware. And when it comes to diagnosis, there are a lot of challenges. One is, of course, there are no definite pathognomic features. There are no specific biomarkers like we have for some of the ovarian tumors or endometrial tumors. And of course, the definite diagnosis comes from histology. Most important, even if you see a lesion, it does not mean that it is because that is the cause of symptoms. It could be something else. And if you don't see anything on imaging or whatever, it still does not rule out endometriosis. So that's a big challenge. And very often between what you see and what is the extent of disease, there's a big gap. So overall, there are a lot of challenges to be faced. And of course, Narendra has pointed out that very often there's a delay in diagnosis, and more the delay, it causes a lot of problems for the lady in terms of treating her in the near future. And sometimes, of course, almost about 6 or 10 out of 10 endometriosis cases are misdiagnosed. And this is where an expertise of the clinician as well as the imaging person comes into picture. So after Narendra or a clinician suspects endometriosis, and he does the basic test, the next thing he's going to ask for is imaging modality. And this is important from the point of view of not only diagnosis, but also from the point of view of mapping the disease, looking at severity, and of course, planning the triaging the care. And so imaging plays a very important role because it not only helps in diagnosis, it helps us in planning what we should do for this particular lady at a later stage. And here I would say that when it comes to imaging and endometriosis, you do require expertise, whether you're doing ultrasound, whether you're doing CT or MR. A special focus on this disease is very, very important because this is quite different from a lot of other diseases which we see in day-to-day practice. Now, this is important because imaging is important because it tells us whether the disease is restricted to the ovaries, whether it is superficial endometriosis, which is just on the surface of the peritoneum or major or some organs, or whether it is something known as deep pelvic endometriosis, which is going to take probably a different type of surgery. So if you look at the list of surgeries which are done laparoscopically for endometriosis, the list is very vast. It starts from just a cystectomy to radiolysis to ultimately even hysterectomy, bowel dissection, etc. So before a surgeon puts in a scope or before a surgeon sort of opens up the patient, he has to be aware of what is the extent of the disease. This is very important because if, for example, the lady has involvement of the ureter, involvement which is damaging the kidneys, then he would like to have a urologist in his team. Rather than have a surprise and then call someone frantically from the OT, it is better that he's prepared. If it's involving the intestine, he might want a GI surgeon in the team because sometimes these resections can be deep and sometimes there might be resection of bowel, there can be reanastomosis. So the type of surgeries are really variable. And before this surgeon, I'll come to this point a little later, before the surgeon puts in a scope or opens up the patient, it is extremely important that he is aware of the extent of the disease. And this comes through imaging. And when we talk of imaging, we have various techniques. Imaging starts right from plain X-rays to ultrasound to CT and MR. And it is very important to choose the right modality for the right thing. And as far as gynecology is concerned, in overall, ultrasound plays a very, very important part. So just for since we have some patients who have logged in, as far as ultrasound is concerned, ultrasound means high frequency sound waves, and this has been used for bats to catch their prey. And when Titanic sank, they realized that they were not able to judge the extent of the iceberg below the water. And this is where they started coming up with things like oscilloscope, which were put in the water to find out what is happening below. And in the World War II, they had this sonar equipment which tried to pick up things on the seabed, whether it's a mine or a wreckage of the ship, etc. So during this World War II, there were some people, the British Navy doctors, who were sitting on the shore, and they said, "Why don't we take this machine and try and see what's happening inside the human being?" And then they tried to take an image of the skull of the patient or a person, and this is one of the first ultrasound images which came up in the history. But then things progressed very fast over a period of time, and today we have very sophisticated machines which are very compact. They can go anywhere. They can go in the OT, or they can go anywhere in the hospital or in the clinic. They are very compact. They are very versatile. There are a lot of AI features nowadays. We can talk with the machine and give commands, etc. So it's become a technique of choice as far as most of the gynec problems are concerned. And why it is the first modality now for gynecological problems like endometriosis is because the resolution of the present day machines, especially the endocavitary probe, which Narendra mentioned, the transvaginal, transrectal probes, have a phenomenal resolution, which is as good or better than MRI because we are going very close to the organ of interest. Ultrasound has several other advantages. It's very cheap. It's commonly available. Almost like every nook and corner of your town or city would have an ultrasound machine. There is no risk to the patient of radiation. There's no discomfort. We have various probes which can be used. It's a very versatile technique in the sense that when you see, okay, there is some endometriotic patch outside the uterus, or the ovary is affected, and then you want to see whether something is going wrong in the abdomen, like whether the kidney is affected, whether the ureter is affected. You can just change the probe and go from one end to the other. It's a very, very versatile technique, and that makes it, that's a big advantage of ultrasound over other modalities. So it is the first imaging modality which a clinician like Narendra would ask for. And the most important thing and the most biggest advantage of ultrasound is that it's a real-time technique. It's a dynamic technique. That means you can do something, look for movements of organs like the ovaries, etc. Ask the patient, is there pain at this point? This cannot be done on a CT or an MR. And that's the biggest ultrasound advantage of ultrasound over other imaging modalities. Now, when a patient, as a patient, if you go to a clinic for evaluating endometriosis to an ultrasound center, it is very important that the clinician, that the sonologist or radiologist is aware of the fact that he's looking out for endometriosis. And this is where the clinicians play a very important role. They should be very clear in their thought process that, okay, this is a patient who is suspected to endometriosis. The reason is that the preparation for the patient is different from a routine exam. So when we do a routine ultrasound, we never ask for bowel preparation. We normally, when we do a transvaginal scan, we would ask the patient to empty out the bladder completely. So as opposed to that, when you're looking at a patient who is suspected to have endometriosis, then we ask a bowel preparation, because we not only want to see the uterus, ovaries, we want to see the layers of the intestine, rectum, whether there is an endometriosis sitting there, and if it is there, how deep it is going. This is very important. Similarly, we want to see the bladder wall. So we don't want the bladder to be totally empty. We want it to be partially filled. So there is a lot of difference between a routine ultrasound and an ultrasound which is targeted towards diagnosing endometriosis and staging endometriosis. And this has to be, the person who is doing it should be aware of this. This is very important. So we typically divide it into 4 steps. Like the first step is just routine evaluation. Then we do look out for what are known as soft markers, mobility. Then we look for the sliding sign, the pouch of Douglas, and then we look at anterior and posterior compartments differently. And this is how typically ovarian endometriosis looks like. This is known as ground glass appearance. Now, how do I diagnose this? How do I know it is endometriosis? And this is done by a very simple way, and that is known as pattern recognition. Now, what do we mean by pattern recognition? Now, if you see something coming in from the sky, oh, this is a helicopter, it's a balloon. This is a drone, which is nowadays they go all over the place. That's a parachute. And that's, if you're lucky, you might see a spaceship coming from an outer planet. So how do you recognize them? You recognize it by the pattern. And this pattern has been fixed in your mind. Similarly, for an expert sonologist, when he sees an ovarian lesion, which has got this pattern of fine internal echoes, he knows this is endometriosis. He doesn't have to think about what this is. So typically, the diagnosis is done by what is known as pattern recognition. So here we have different ovarian lesions like a simple cyst, an hemorrhagic cyst, endometriosis, dermoid, etc. And this comes to a sonologist naturally because he's doing this day in and day out. Now, the other important thing is we look for mobility. And normally, the ovaries are very mobile. So if you press with the probe, the ovaries moves, they slide against the uterus, and everything in the pelvis, in fact, is quite mobile. But as we'll see later on, if you see that the ovaries are not moving when you press with the probe, then we know that there is restricted mobility. So the other difference between an ordinary ultrasound, transvaginal ultrasound, and a test which is done for mobility is that we tell the patient that, okay, in your case, after we do a basic scan, I'm going to press and I'm going to look at surrounding structures. I'm going to look at movements of uterus, movement of the ovaries, uterus, the anterior sliding, posterior sliding. So I'm going to compress, but this is not going to be very uncomfortable or painful to you. You might get little pain, but you have to be aware of this. So that's a very important message which we need to give the patient. So the point is that the patient has to be aware, the clinician, the one person who is doing is to be aware that, okay, he's going to look at endometriosis. So not only he prepares the patient, but he makes the patient aware that, okay, in your case, after doing a basic scan, I'm going to do some maneuvers where I'm going to push the probe. I'm going to look at whether the uterus is moving easily, whether there is any restriction of movements, etc. This is very important. And in fact, I think so that the patient is aware that, okay, this doctor is going to do much more than a routine scan. And she is aware, she is sort of anticipating that little bit of discomfort, if at all she has. So this is just an example how deep pelvic endometriosis looks like. That's an endometriosis in the pouch of Douglas. This one is in the bladder. This was one of our staff nurses from Jaslok, and she had endometriosis in the bladder. She had a painful maturation and hematuria. And this is how typically it looks like when it involves the intestines or the rectum. So this is because, it sort of forms sleeves. There's fibrous tissue and there are endometriotic patches which go onto the bowel surface. This is typically known as an Indian headdress sign because this mimics the Indian headdress. And some people would like to call it the moose antler sign because what we have is the sleeves of tissues and then fibrous tissues which are sort of going into the rectal wall. So in fact, this month, March, we wrote an article on rectal endometriosis in our World Federation journal, and this was published. This is now an open access journal, so anyone is interested can see this. So this is a sort of a pictorial essay on various rectal endometriosis, which we picked up, and there was offered surgery. Nowadays, we see a lot of scar endometriosis. That means patients who have undergone cesarean section. They come with pain in the abdominal wall, which is superficial. And when we do a high frequency probe, we see this typical endometriosis. In ultrasound, we now have new techniques which might be useful. For example, if there's a doubt, we can do contrast, which we do very routinely. We can do elastography to look at characterize the lesions. We use what is known as gel vaginosonography. This is very useful when you want to see the superficial endometriosis at the rectovaginal pouch, because then you can actually see that area much better. We do what is known as sonopodography. That means we inject saline, and when it goes into peritoneal cavity, we can see the pouch of Douglas, the rectal wall much better. We have 3D ultrasound. And as Narendra said, if we have a female who is not married, then what we do is a transrectal ultrasound. So in our center, we do transrectal ultrasound in any adolescent or unmarried women. It's a very painless procedure because we have special probes which go into the rectum, but that is very important. So in spite of, so ultrasound can basically help us in staging, and a good number of times based on ultrasound staging, the surgeon takes a decision on operating or doing a laparoscopy, and that is going to be enough. But as we would know that everything has limitations. So similarly, transvaginal ultrasound, one of the problem is that the field of view is limited. So beyond a certain area, we cannot see things which are much beyond that particular scope of the probe. And this is one of the limitations of ultrasound. And therefore, some situations where we feel that there might be something more than what we have seen, we might ask for other imaging modalities. And these imaging modalities are CT scan and MRI. But when it comes to endometriosis, CT scan has a lot of limitations. It is not the modality of choice. But we use it for specific situations. For example, if you think that the ureters are involved, if you think that a kidney is probably damaged because of the ureter is involved, this is the place where a CT would be useful. Otherwise, most of the times, what we do is an MRI, if at all required. Now, MR has a big advantage in the sense that it has got a lot of specificity, in the sense that we know that endometriosis has blood products. So depending upon how it looks like on T1 and T2 image, we can be very specific and say that this is a blood containing tissue, and therefore this is likely to be an endometriosis. So just like we have signs on ultrasound, we have signs on MRI. That's a deep infiltrating MRI. Endometriosis, that's again a large patch of endometriosis behind the uterus and involving the rectal wall. So when it comes to rectal endometriosis or deep infiltrating endometriosis, involvement of uterosacral ligaments, etc., again MRI plays a very important role in staging the disease. So this also has limitation. So the point is that nothing is going to be 100% sure. You know, in life we know that 100%, there's nothing like 100%. Each modality would have certain limitations, and an imaging person is probably the best person to judge what is good for a particular patient, and he can sort of try the imaging modality for that particular patient. This is very important. Now, this is important because, for example, if you have water and you want to dive, now, unless you know that what is the depth of this water, you're not going to dive. And you know, we had an example recently in our city department where a person saw some water, went for a picnic, saw some water and dived, not knowing that it is only 2 feet down, and then he had a injury on the head because he just hit the bottom. So just like you are not going to do anything of this sort unless you know what is the depth of water. Similarly, before you put a scope or before a surgeon puts a scope, it is extremely important for that surgeon to know what is the depth of the disease. Is it just restricted to the ovaries? Is it superficial endometriosis, just pockets, dots on the peritoneum, or is it deep pelvic endometriosis? And if it is deep, then what are the organs it is involved? Even if it is involving the rectum, how much of the rectal wall is involved? Because a lot of things will depend upon that. So do not put a scope unless you have done a proper imaging. That is a very important lesson. So as Narendra said that, you know, in future, we wish to help the patients. We need to create an awareness, and awareness should be created not only amongst patients, but also amongst doctors, among imaging people. Just like here, students, we have a lot of students, we have fellows with us. So we teach them about how specifically to look out for endometriosis, and we do it in our radiology groups also. When we do lectures, we teach them that endometriosis imaging is different from our routine pelvic imaging. In a routine, you might just look at uterus, ovaries, etc. But here we need to specifically look out for certain things, and we need to follow a sequence of events as per the guidelines. Thank you so much for the attention. If there are any questions, I'll take them, and I'll be traveling a little after this.
Thank you, sir. So, yeah, since you're traveling, just two quick questions from my side.
Yeah.
One is there has been, you know, leaps and bounds in terms of radiology and radio imaging techniques moving forward. So how many gynecologists would be aware of these advances? Because what the mind does not know, the hand cannot write. I mean, if I want a specific imaging, I can only write if I'm aware that there are these facilities available. So would small town gynecologists or rural gynecologists be aware of this, and would they need some kind of skill building in this?
Yeah, I think now this awareness is increasing day by day. And with, you know, last 2 years, everyone sat at home, but then people listened to a lot of webinars. So that has increased definitely an awareness amongst everyone. So awareness is increasing not only amongst clinicians, but also amongst imaging people themselves. So I think with time, and sometimes someone may burn a finger, and then you learn a lesson, and then you're aware of it, you're aware of something much more than what you were. So overall, I think awareness is gradually increasing, I would say, amongst clinicians at all levels, as well as amongst the imaging people.
Thank you, sir. And the second question is related to access. So where would these imaging facilities be available? Is it only in big towns and metropolitan, or is it now penetrating to smaller towns as well?
We have imaging at every nook and corner of the country. thanks to a lot of private companies. See, as far as ultrasound is concerned, most of the imaging people would have a good ultrasound machine. Most of them have a transvaginal probe. I don't think that is a major problem. Even if you go to a very small place, like for example, from Bombay, you go to Alibag, something like a district place, you will have so many ultrasound centers. They're not a problem. CTMR again now is available in abundance everywhere, because there are a lot of private players who have come up, not only the institute, but there are a lot of private players who have come up. So, I mean, I don't think availability is a challenge as of today, as compared to what it was 10 years back. In the last 3, 4, 5 years, I think we have moved ahead, and availability is not an issue at all. It is awareness and asking for the right thing at the right time. That is very important, and sending the person to the right place.
Thank you, sir. Thank you so much for the.
Yeah, thank you so much.
Sorry, thank you so much for the insightful discussion we had just now. I mean, even though I am a physician, I didn't know that so many options were available. I did know about transvaginal and MRI, etc., but there seems to be so many things that are available, and it is very useful to know that, we can actually ask if some of these could be made available for patients who suffer from these conditions. So thank you so much.
Thank you so
And
much.
we will now move on to our next speaker, Dr. Meenakshi, who will be addressing the multidisciplinary approach to treatment for endometriosis. And this particular topic has been chosen because we know that people who suffer from endometriosis also have psychosocial problems, relationship problems, workspace problems. And in general, they don't know how to manage themselves or their nutrition and their pain, etc. And they feel that the whole world is against them, or people are not listening to them. And it really needs an empathetic gynecologist to be able to go beyond just the disease and look at the person as a whole. And Dr. Meenakshi has been advocating for this holistic view of managing endometriosis. So, ma'am, over to you for your views on this.
Thank you so much for having me here. And without much ado, I'll go to my topic. I don't have any slides since this is a very general topic and I wanted to talk directly to the audience about this. So like we are all aware that 1 out of 10 women actually suffered from endometriosis. And it's a disease where the endometrium lining, which is there, which is normally in the inner side of the uterus, kind of starts growing at ectopic areas, that is at other areas rather than just the uterus lining. And since the blood collects there like every month during the menstrual period, it stretches the tissues, which causes pain. Now, like you said very clearly, that I think probably when we talk about a multidisciplinary approach, the first issue that we have as far as endometriosis management is concerned is the awareness itself. And that's where in the multidisciplinary approach, the first person I would like to count in this is people like you, Dr. Ratna, who actually go in the public and talk about it, because it is only awareness and knowledge that so that a person understands that these are the problems that we are having and then approaches their doctor. So I think that's where the first discipline which is required, whether it is the media, whether it is awareness from the pharmaceutical companies, or whether they are NGOs or people working, so that the awareness is there among women, among teachers, among workspaces, so that people understand that there is a disease known like this and not just normalize period pain. In fact, now in Europe, there are certain countries who recognize period pain so well that there is leave sanction for it. Of course, unfortunately, something like that has yet not come into India. But I'm hoping that we soon see that day, because I guess probably the problem with endometriosis is that the pain can be understood only by a woman who's going through endometriosis. That's number one. And they are seeking empathy, not sympathy. And number two, the problem, like Dr. Narendra Malhotra mentioned, that it's almost like a benign cancer. That is, it's going to stay with you once diagnosed also for a lot number of years. And it is probably because it's an estrogenic hormone issue. And till the time your estrogen is being formed, which is till the time you reach menopause, that we are going to have some of the other issue as far as endometriosis is concerned. And we need to treat it till that time. So it's a very long time span. It's probably going to go away. It's not going to turn into cancer in 99.5% cases. But the problem is that it is there with you for a long time, and it is going to affect you in one way or the other. And it needs management, and management is available. Firstly, if you pick it up early, that is probably where the awareness comes in. And it's very important that if you have period pain, say, or if you have severe pain during periods, or pain during sex, because the endometriomas may cause that. You may have painful bladder or bowel issues, especially during the periods, and of course deep pelvic pain, which may not even be related to the periods. So don't normalize these things. That's the first thing. Of course, in our society, with with infertility associated with endometriosis, you'll probably land up with a gynecologist at some point of time. But the awareness in the public itself is probably the first discipline, I think, which needs to be very active in this. Then after that, probably I would say that since we know that there's a lag of about 7 to 8 years from the time we make from the time the patient has symptoms or the endometriosis actually starts in the body, we have to be aware that it is a problem which is there even in adolescence. And that is why probably the general physician and the pediatrician have a role there. They need to understand that if a girl has painful periods, she needs to be, and the problem here again is, although we just discussed with Dr. Nitin also that there are a lot of modalities which are available on ultrasound, but not all endometriosis, especially if it's tiny, can be picked up on ultrasound. And we don't want to do laparoscopies for every person. So sometimes it is also the history and examination which would give us an idea. And even though we may not see something on ultrasound, probably a therapeutic challenge of giving some medication and seeing whether it works and makes the woman feel better would be a good idea, because as time advances and by the time the lesions are picked up, probably it's not just pain, but also infertility, which will set in, because the tubes and ovaries can also be affected. And of course, the fertility potential of a woman would also go down. So after the awareness, and I think it's the pediatricians and the physicians who have a very major role to play in this. Now, once a patient reaches a gynecologist, I can't deal with this alone, because I need to, in a way, when a person comes with problems, I understand that it could be this, but there could be other issues also which are there, which could mimic endometriosis. And that's why I need, like you very rightly pointed out, a very good radiologist. So I think endometriosis, with the multidisciplinary approach, it's very important to involve your ultrasonologist, radiologist, and have a person you have faith and trust in, and who will do a good job and an impeccable job, because endometriosis literally has to be hunted out. It's not something which, if you just write a pelvic ultrasound, it's the person will just see one uterus, two ovaries, and just say, yeah, it looks okay, or just write a hemorrhagic cyst or a cyst. The diagnosis, Dr. Nitin just told us so many ways that we can diagnose. But again, it is like you said very clearly, that it is the mind will, what the mind knows, the eyes can see. So you need someone who is competent in diagnosing endometriosis. And that's why I feel that in the multidisciplinary approach for any gynecologist to manage endometriosis, you definitely need a good radiologist on your side. Now, the awareness that surgery is not, number one, the only option, and number two, it is not the first option. So Dr. Narendra Malhotra has spoken a lot about when surgery is required. So all of us should be aware that just because you go to a doctor with a cyst and the doctor says that, let's just get surgery done, be wise about it, because now in today's time, we don't want to operate on endometriosis more than once. And that needs to be done. If it needs to be done, probably if there's infertility or the medications don't work out, which in 90% will. And again, if picked up at the right time, treated at the right time, it won't reach a stage where surgery is required. The medications which are available today are wonderful. So that awareness has to be there, that, if you take treatment at the right time, you may not even require surgery. Again, because endometriosis, like we discussed, it's ectopic tissue which is outside the uterus. So it could be in the ovaries, it could be in the tubes, could be involving the bladder, could be involving the bowel. So you need a very good laparoscopic surgeon, someone who is technically good. We don't do surgeries or laparoscopic surgeries today to diagnose endometriosis. It is only to manage it. I can't be the person who puts in a scope and comes out saying that, yes, it's endometriosis and looks inoperable. No, when I go in, I go with the mindset that I have to preserve the woman's fertility. and at the same time, do a surgery which cleans up as much endometriosis as possible, gives a pain relief, and does not damage any other organ. So many times I may need, if I know that there's a bowel involvement or a bladder involvement, here again, I need a multidisciplinary approach during the surgery itself, having a, maybe a GI surgeon or a urologist alongside, someone who can deal with the bladder, so that we are sure that we deal with it in the safest way possible. And that's again where the multidisciplinary approach comes in. Now, like I said, surgery is not the only thing which is there. There's medical management. And at some point of time, if infertility drops in, I need an IVF expert. I need fertility experts, because here there are couple of things. Women now trying to delay pregnancy because of their profession, work, or otherwise till longer. And you know that endometriosis is only going to advance with age, and where your tubes are going to get damaged. I don't think it's a bad idea to even discuss with your fertility expert, with your gynecologist, about freezing your eggs at the right time. Because as time advances, fertility issues are going to be there. And when we operate, or if we need to operate on the ovaries, definitely we are going to be in, somewhere or the other, some sort of normal ovarian tissue may also get damaged. Also, while the cysts are growing larger, they're probably going to be pressing on the normal ovarian tissue. So there again, we know that there is going to be pressure on that. And that's why having a fertility expert with you, or an IVF expert who can discuss the options which are there, that whether we need to freeze the eggs, or when a woman should conceive or not delay conception, because at the end of the day, if that is a priority for the women, it needs to be discussed right from the beginning, and that's why it needs to be taken care of. Now, like I've been talking for so long, pain, probably that's the trauma a woman suffers with endometriosis. And the problem is that other people don't understand it. And that's where, she may need even a mental health expert to help her understand, and probably, mental health experts sensitizing the workspaces about how the pain is and how people need to be empathetic. Not only the workspaces, I think even at home, even the family setup, the husband needs to understand it. The mother-in-law needs to understand, the children need to understand it, that it's actually not just something someone is imagining, but it's there, and she's trying her best to deal and live a normal life. But there, the psychologist, the mental health expert really comes. And again, I think multidisciplinary here again comes in, that we need to talk about it more. It needs to be out. People who have endometriosis should be discussing it. And wherever, as doctors, we ask for the family to be there, whether it's a girl's parents, her partner, her family, because everyone is affected. Workspaces, I think we just need to be having more sessions like this to have awareness coming in, and so that people understand that pain is something which needs management. There are also pain management experts there, and like discussed in the previous thing, there are alternative medicines which may work. So that also, I think with endometriosis, when a person is desperate and has pain, whatever works, but she needs to be comfortable. That's the sensitization which needs to be there. I don't think in today's medicine we can talk about anything being okay without help from nutritionists and physical health experts. So I think nutrition has a very, very important role to play. And so many patients of endometriosis who would come to me, they have to learn that it's not the blame game, because the first thing they say, doc, did I do something wrong that I have this problem? I think, that's not a problem of endometriosis, it's a problem of every woman. The minute that we've been brought up with that guilt thing in our heads, that whenever something happens, the first thing is, where did I go wrong? Someone has a miscarriage, the first thing she asks, doc, what did I do wrong? So you have to understand that it's not something wrong you did, but it's there. So let's just make it right. And the next question is going to be, is there something, with the medications, is there my diet which can help? So I'm actually quite looking forward to Radhika's session also, because I also want to understand that, because it's not only about the disease that you may need alterations in your diet, but also the medications that you may take if they have little GI upset, and also with the medications also, or see, it's a disease of high estrogen. And that's why it's going to stay till the time you don't get menopause. Now, what do I do with estrogen? I mean, I operate it also, it's going to come back, because estrogen is going to stay in your body. So for that high estrogen, either I decrease the estrogen. that means I create an artificial menopause, which is going to affect the woman's bone health also and other issues, vaginal dryness and all. So there are things that, I need even in her nutrition to take care of for her bone health. The second thing I can do is to balance that high estrogen, I'll give her progesterone, right? Because estrogen and progesterone are the two hormones in a woman's menstrual cycle. And this is the abnormally high estrogen, which is causing this problem. So probably progestogens work beautifully with endometriosis. But, someone can have little GI side effects or something, but which are quite tolerable. But at least a nutritionist who helps her through this time. I think that approach, we need to understand that I can't do everything. We need to work as a team. Similarly, we know that regular exercise releases again, I think the happy hormones. So having in your food, your diet, there are a lot of things which actually help you with pain relief, which help you feel happier, be able to deal with the situation better. So probably that way, I don't think I can undermine the importance of a nutritionist. Physical activity, exercises, something to help her with her pelvic pain. That's number one. I think we need to understand that we will need someone who is an expert at that, physiotherapists or exercise people. Also, normally exercise again releases endorphins, which help you cope with better. There could be postures and situations because sex can be painful. So probably a little bit of yoga or something, learning how to relax your pelvic muscles, because, when you have painful sex, it kind of keeps on getting compounded. What happens is that there's little pain. So now the next time you have sex, you're so scared that there's going to pain that you're going to tighten up and it's going to be even more painful. So probably someone who can help you with mind relaxation as well as physical relaxation. So it's not only the mental health expert, but also to help relax your pelvic muscles and all, so that it becomes easier for you. Because at the end of the day, she's a young woman. There is no reason why she should not be enjoying at least a sex life which is fulfilling. So it becomes important that you may need someone who can help her on that account. Now, I think when I talk about experts, I still, my job is not complete till the time I talk about menopause health experts also. Because like we discussed, till the time the menopause doesn't happen, your endometriosis is not going to get okay. So even removing the uterus is not going to help, because the disease is not in the uterus, it's in your ovaries, tubes, gut. So the uterus removal is probably just going to help you with the painful cramps or the heavy bleeding if that occurs. But otherwise, because it's there elsewhere, we are not removing those tissues, right? And secondly, the estrogen is being secreted by the ovaries, not by the uterus. So if I've left the ovaries behind and removed the uterus and the cyst, but left the ovaries behind, the endometriosis is still going to recur or cause issues in the other tissues, because estrogen is a hormone which is secreted by the ovaries, which is going to go to the rest of the body. And it's going to act wherever this ectopic endometrium tissue is, and it's going to make it grow. So that's why that clarity has to be there, that the ovaries need to be removed if I want actually complete management. And now, in a woman who is not at the age of menopause, sometimes she may have so much excruciating pain, she will insist, or I can't offer her relief, I will have to offer her surgery where I need to remove her uterus as well as her ovaries prematurely. See, the ovaries will function normally till 55. And also, but at 35 or 40, if I really need to operate on her and remove her ovaries, or at 42 or 45, I need to give her support so that the menopausal problems, I get her from one thing, to कहते हैं ना, क्या पेड़ बबूल से something गिरा और दूसरे पेड़ में अटका or something like that. So actually what happens is कि एक जगह से फंस के वो दूसरी problems में आ गई ना. I have to look at her holistically. So I will need a menopause health expert who helps me with her premature menopause. She may get hot flashes after that. She might get vaginal dryness after that. Her bone health is going to be suffering with premature menopause, so as to say. So there again, I have to understand that I need someone who's a specialist in that. And that's why, all I need to say is that it's a very strong teamwork, from starting from, probably NGOs, awareness, the people who can create awareness, allied fields, nutrition, mental health, physiotherapists, exercise, yoga trainers, Alternative medicines like acupuncture, acupressure may also help. And of course, with gynecologists, general surgeons, laparoscopic surgeons, I would need my menopausal health expert. And so it's a big team which needs to, and of course, our radiologist for the diagnosis itself. Thank you.
Thank you, ma'am. That was excellent in the way that you explained the entire care continuum pathway. I have two quick questions. One is, when you talked about multidisciplinary approach, we know a lot of laparoscopic surgeons who also do surgeries, though they are not gynecologists. And we also know many gynecologists who do excellent imaging. I have seen gynecologists who do transvaginal in their clinics as well. So how do these fit into the multidisciplinary approach? Because many of our patients ask us, they are not gynecologists, should we go to them for our surgeries? Though those surgeons are sometimes quite good in their field and they have an excellent reputation for these kind of surgeries.
So this is two questions. Number one, the gynecologists who do radiology work. So if you have proper training and proper experience, and you understand the symptoms, you're not missing out. But every doctor can take the training, every gynecologist can take the training for that. On a personal front, I don't do ultrasounds. Dr. Narendra Malhotra does wonderful ultrasounds. So as long as you have the training and the experience, it's okay. But I believe, if I worked so hard, so many years in gynecology, because I do a lot of other things also, and not just endometriosis and fertility management. Probably I will need my good radiologist with me, because I feel that he has that many years of experience in that field. And like you said, to remain updated. But the point is that, a gynecologist who has interest in ultrasounds can definitely, if they are experienced, have the training and have that, learning graph and keep themselves updated. Why not? But probably I like I said, my limitations are there. I don't do ultrasound. So I will definitely rely on my ultrasonologist. The second question that you asked was that general surgeons doing laparoscopic surgery for endometriosis. See, personally, I believe that your gynecologist understands your uterus and ovaries the most, and your future fertility and scarring to be avoided during surgery, how your ovarian preservation is done, is probably best understood by gynecologists and gynecologist laparoscopic surgeons. If as a gynecologist, I don't have the training for laparoscopy, but I want to do laparoscopy for my patient and give her the best thing, I still think the primary treating doctor, even during surgery, should be the gynecologist. She will probably call a general surgeon with her, whom she's a laparoscopic surgeon, whom she's familiar with. But I mean, pardon my saying so, I think sometimes general surgeons who are laparoscopic can be brutal with the ovaries, I think that sensitization towards a woman's ovaries as well as a uterus can't be more than with a gynecologist. But yes, like I said, a gynecologist, when you take the decision for laparoscopy, either you're doing it yourself, even if you're getting it done from a laparoscopic, non-gynae laparoscopic surgeon, then be there, because you can, you are part of the management. You know what has to be done. You may not have the technical skill to do it, but you know what has to be done. So your primary treating physician on this role, I at least believe that it should be your gynecologist.
Thank you, ma'am. And so the follow-up question to this is, this needs a real team to work together for patients. So do we as a country have any protocols for this team to work together, or is it on an individual as to how they bring together all the specialties to be able to manage a patient?
I think, unfortunately, healthcare for even basic things is quite dependent on the private sector, like you realized even at COVID. So very candidly, this is a small group, I can say that the private sector actually has to reach out. And I mean, look at Rajasthan, they even want private doctors to work on everything for free, and manage. It's somewhere, I think it's not the tax. Some money has to be involved in this. Some efforts have to be involved. So I don't think as of now, we have any government initiative which works at combining all of us together. But I think all of us who are doing good endometriosis work always work as a team, because like you said very clearly at the first time, you have to manage the patient as a whole. And I think that's the only way patients stick to you also. I can't just
Okay.
focus on one ovary and just forget about the rest of it. So, and it's a long curve. I diagnosed endometriosis for a girl at 18 or 20. And then I'm with her through her college years with the pain and all. I'm with her through her fertility years. Once she's completed her family. And that pain relief I need to manage till 45. She also will stick, or 50. She's also going to stick with me only if, I involve all specialities and give her treatment as a human being, wherever her problems are.
Thank you, ma'am. Thank you so much. As always, you are very, very lucid and beautiful in the explanation that you give on the topic. So thank you so much. And Vikas, if we are ready with the recorded session, we'll move on to that, or we can. Just to give a brief introduction, Peter heads the APAC region for patient engagement, and we thought of bringing him in to hear from the pharma perspective on, because they speak about patient engagement and patient-centeredness. What does a pharma company look at when they talk about patient engagement? And since he is in a different time zone, he could not join us in person and has sent us very kindly a recorded session. So if Vikas could play it, please.
Thank you for inviting me to speak today. Before we start, I wanted to set the scene and have you think about some of the big decisions that you might make in your life today. Now, this could be around a new place to live or applying for that new job. And you'll know that these are some of the biggest decisions we'll probably make in our lives. So it is pretty uncommon for us to simply make a decision without any input or based solely on someone else's advice. Now imagine stepping into that new job or a new home without any input or consideration for your lifestyle or budget. We just wouldn't do that, right? So why should healthcare be any different? So here is my disclaimer. Okay, so let's first start by understanding that traditional patient-doctor relationship. And it's often one that we see as paternalistic. Now, in the context of, say, my parents' generation, as well as in many cultures around the world today, the relationship between the patient and doctor is not too dissimilar to the parent-child relationship. And it really has stemmed out of a large respect for the profession, with that white lab coat often a symbol of power and unquestionable authority. So doctors have always enjoyed an undeniable prestige when it comes to their patients. Doctors know the truth, doctors know best, and doctors decide. Now here the doctor takes on the role of the parent, and they're expected to patients are expected to follow the instructions. And so the focus here is on care rather than autonomy. Remember, the intention is always good, with decisions often made for the good of the patient. Now, there is a bit of a revolution happening, and I like to call it the patient revolution. It's a very important movement that is changing and shifting the power for patients in a very positive way. Now, it's not aimed in any way to undermine the important and respected role that healthcare professionals play. Rather, it's designed to improve the dialogue between patients and their doctors and really aims to put patients in the driver's seat of important healthcare decisions instead of just being passive recipients of information. So why is there a shift towards engaging and empowering patients that is really driving this? And I think there's a few things that are driving this today and are really shaping the healthcare environments, which is now giving patients more power. The first is actually patient voice. So patients are now playing an important role in healthcare than they've ever done in the past. And they're becoming more empowered, especially now in the digital and social media age. And this has really accelerated the position of patients in a very positive way. The relationship between patients and their doctors has also shifted. And as you will see, patients are no longer just happy to receive information. And with the health of and access of health information today, they want to be part of healthcare decisions. Number two is this thing called the connected society. So patients now are even more connected than they've ever been in the past. And as a result, we've seen an increase in digital literacy. So whether that's in the context of communication, such as telehealth or telemedicine, tracking data, or therapeutic devices such as iPhones and iWatches, digital now plays a very important role in healthcare today. What this is doing is making healthcare very tangible and accessible, and in turn creating real opportunities for patients when it comes to making important healthcare choices and decisions. Now, the impact of COVID-19 on the healthcare industry has created some challenges, I admit, but it's also represented some opportunities. And as a result of the pandemic, it's really highlighted a willingness and a desire to adopt new ways to communicate. Now, today, most people are familiar with the use of the humble QR code and also telemedicine when it comes to new ways to access information, or certainly to communicate with each other, especially between patients and their doctors. Now, lastly, we are living alone and we're living longer, and this is forcing greater public health initiatives due to this ageing population. So there is an increased focus on ownership of health and self-care. And in addition to this, as mentioned earlier, is this adoption of digital. And what this is doing is such as smart devices, and we're now seeing that more and more in the older population who are really embracing technology, making healthcare more tangible and within reach. So, as I mentioned earlier, patients are increasingly becoming more involved in healthcare choices. And again, they're not happy just to or content just to simply fill a prescription simply because it's been recommended by their doctor. In a report of about 13,000 patients, 89% actually initiated a conversation with their doctor about their treatment, and 70% think that decisions should be a collaborative effort made with their doctor. Now, you're probably all thinking this is not everybody, and I can appreciate that this doesn't represent every single patient, nor is this something that will happen overnight. But I think the good news here is that we're talking about this, and this is something we should really aspire to. We want patients to take a more proactive role in healthcare. The good news is that patient empowerment is becoming more than just an aspirational goal, and we are now defining degrees of patient engagement. And this is becoming increasingly important in the pharmaceutical industry as well. So if you look at the dimensions of patient engagement on the screen, there are many ways to engage patients to help and ensure that their voice is heard and incorporated into any healthcare decision that's being made for them. From as simple as gauging patient satisfaction right through to informed choice and shared decision making, right through to its highest level. And this is where we have patients or people engaged in population health. And here, patients are pivotal in engaging for advocating for the health of communities, as well as influencing health policy. So when we listen and take into consideration the unique patient perspective, one that is based on their own lived experience, it actually takes a healthcare conversation to what matters to you instead of what is the matter with you. And if you listen to those words, there is a profound difference. By doing this, we change the dynamic. One that was largely passive to one that centers around collaboration and true partnerships. So, what is really important to remember that when it comes to the patient and doctor relationship, there are actually two experts in the room with different types of expertise to offer and consider when making important healthcare choices. Now, if we think about the clinician or the doctor, they bring to the discussion and information and clinical expertise around a host of things, including disease, diagnosis, prognosis, evidence-based medicine, treatments and tests and outcomes. And of course, there is the patient. They are the other expert who brings to the discussion the lived experience. And that might include things like social circumstances, personal circumstances, attitude to risk, preferences, and also what matters to them most. So we need to continue this important conversation and look for opportunities to partner with patients across a much wider health ecosystem that really aims to help patients facilitate an open and sustained conversation with their doctors. Now, patient engagement is now an important function within the pharmaceutical industry. And as a patient in this slide has quoted, the people who rely on your products, they want to work with you. They want a dialogue. They want transparency. And they are the ones, they're the experts living with a condition. They are an asset to us. So as a pharmaceutical industry, our principal goal, or our principal role, should I say, is the development of new medicines to treat a range of conditions. But we spend a lot of time focusing and understanding the perspective of healthcare professionals. But there is a strong need and a growing need to gain a deeper understanding of the challenges patients face by having real depth in consultation with patients and patient groups to truly understand the lived experience perspective. Now, when we engage patients at all stages of medicine development, from early clinical development right through to when products are out in the market, this can really help humanise the pharmaceutical industry. And it also creates real opportunities to empower patients, create better conversations with healthcare professionals, and in turn develop solutions that actually matter to patients and caregivers. And when it comes to patients, they want to engage with pharmaceutical companies to better understand what patients want from companies like Bayer. And a survey was conducted in 2019 with over 3,000 patients, and they were looking to answer two main questions. The first was, what do patients want from pharmaceutical companies? And two, how well are those companies actually meeting those needs? Now, what you see from this slide is that the three most important attributes were that we commit to affordable access. So affordability is really important. Trials, I'm talking clinical trials, actually reflect real world and outcomes that actually matter to patients. And number three is providing transparent information. And in addition to this, patients want to feel empowered to make important healthcare decisions where their voices are heard and incorporated into any solution. So at Bayer, we are committed to listening to patients' needs and acting. Our vision for patient engagement is pretty simple, and this is always to close the circle. Now, in order for us to start this important cycle, we first need to listen. We need to shift our traditional healthcare professional and product-focused lens to one that really embraces a patient-centric approach, which is really aimed to enhance the patient experience. Here, the focus is to understand or appreciate their needs and challenges in order to develop solutions with them. And this is the ACT phase. And then to ensure we communicate outcomes of the engagement, embrace feedback, and identify areas of improvement. And this is the response phase. Now, words are extremely important. And when it comes to patient engagement, they're even more important. And so often what we hear about is we often talk about what we do for patients. And what we should now be talking about is what we do with patients. So here, the change in words, the focus has shifted on co-creating solutions with patients and caregivers, but also those who represent patients, such as patient groups. So to help demonstrate this important role that patients play and caregivers, in 2021, the Women's Healthcare Team in India partnered with PAIR to support the Women with Wings Endometriosis Patient Support Group, with the overall objective to educate and raise awareness among women, patients and caregivers in India about endometriosis. Now, what was clearly identified was that the patient perspective was not really well understood. Hence, a series of focus groups was planned with women from all walks of life in India to address this important gap. Now, it soon became clear that women had a lot to share about this debilitating and often misunderstood condition that really impacted women from adolescence right through to menopause. It shaped and identified unique insights into what life was like living with endometriosis. And as you can see, heart-shaped icons really help to represent moments of meaning for women who were afflicted. And then you can see the finger-shaped icons. They actually represent touch points that Bayer identified that would like to support and influence with women. And so in summary, I think this quote really sums it up nicely. Nothing about me without me. So when it comes to making important healthcare choices in life, healthcare should really be up the top of the list. And it can often be the difference between life and death. And doesn't it make sense to ensure patients and caregivers are involved in any decision that involves them? And whilst the clinical picture may be similar for many, the individual circumstances, situation, goals, values, and beliefs of patients are unique and play an important role in any healthcare decision. Now, pharmaceutical companies like Bayer support this view and continue to invest in truly understanding and responding to the important lived experience that only patients and caregivers can offer. So I thank you very much for your time.
Thank you, Peter. And as the World Health Organization says, it is in the plural, nothing about us without us. And it's interesting that we're talking about lived experience, because over the last 2 years, the World Health Organization held a series of consultations with people with non-communicable diseases and their lived experience. And in May, they are going to launch a framework which says meaningful involvement of people living with NCDs or non-communicable diseases. Unfortunately, PCOS and endometriosis is still not in that WHO framework, but we are trying to, groups across the world are trying to get this engaged in it. So mental health and COPD was, included after a lot of advocacy. We are now looking at chronic pain, bone conditions, as well as PCOS and endometriosis getting included, not only because of the sheer numbers, but because of the effect it has on quality of life. I'm sure that framework will also help us to understand what meaningful engagement really means. And now we have our star speaker, Radhika, who is going to share with her as her personal journey and help us understand why it is important that patients' voices are heard. And through that knowledge of the lived experience and the evidence that they give us, how can we make our health systems more adaptive, more responsive, and better, respond to the needs of the patients? Over to you, Radhika.
Thank you, Dr. Ratna, and thank you everyone for having me here and looking at it from a patient's perspective and someone who has actually found a path into the healthcare industry for women with endometriosis. I have been living with endometriosis since I was 13 years old. My very first menstrual cycle was painful, and it has always continued further. And whatever perspectives I have are from my own life experience, from being into adolescence, and then being in a relationship, having kids, and then post being a mom and all of that, and how my experiences changed. And without further ado, I would like to first talk about the coping with pain and then discomfort that is associated with working and balancing life for women with endometriosis. And here I want to say from my experiences that coping with pain is more mental than physical. In terms of health sciences, we say that, the body and the mind are two sides of the coin, right? So keeping that in mind, every woman with endometriosis goes through a lot of pain, first mentally, and then it commences into physical pain. So talking about coping with pain, I would like to go through the extrinsic and the intrinsic factors that will help to cope with pain. And to further explain that, I would like to share my screen and give you a glimpse into the pain-free endosystem that I have created for women with endometriosis. And here, if you can see my screen, you can see that, we have an entire module for pain management, right? And here in this pain management module, we give you actionable tasks and first explain to you where to begin with. In order to cope with pain, the first line of action needs to be to identify the pain scale in the first place. And in order to do that, we have this entire report, and where you're supposed to first take 5 minutes to review the form, and then you rate your pain from a scale of 1 to 10 in terms of each and every painful symptom that you have. Because frankly speaking, there is no way to reach a goal, to reach a tangible goal, if you don't know where you're going and what you want to achieve with that. So keeping that in mind, first we need to identify where you are on the pain scale, and then we have certain pain management techniques and certain holistic approaches towards pain management that are effective. And at the end of the day, if nothing else works, we know that we have our medical professionals, we have a gynecologist, we have all of those experts always there to support us. But meanwhile, on a day-to-day basis, on a daily basis, what other actions can be taken is something that we follow with a holistic approach to heal from the pain associated with endometriosis. Likewise, we have the action tasks that they need to be taken. Then we also have the endo drinks that you can consume, especially for the painful symptoms that you have during endo pain or during your menses, or if you have chronic pelvic pain and things like that. So this is mostly talking about the extrinsic factors and how nutrition and how other actionable tasks you can take to cope with pain. And when we talk about nutrition, what I can say is what you eat can either fuel your endo pain or it can diminish the pain. Because if you think about it, from early life to the point where we die, the only extrinsic factor, the external factors that affect our bodily functions is the food we drink, the food we eat, the drinks that we consume, and the other exposure that we have through our skin and all the openings of the body, like endotoxins that we absorb from the skin, the food that we eat. So the first line of action to cope up with pain would be to follow an anti-inflammatory diet as well as an anti-inflammatory lifestyle, which means, again, the exercise part of it. If you cannot exercise, a little brisk walk in nature and 10,000 steps a day, all the very, very simple, basic things that normally women with endometriosis ignore because they are living in the victim mindset that I am in pain all the time and I am just supposed to cope with this and I just have to defend my body and find a safe space for myself. I know it's very hard to believe, but because I've come from that mindset myself, I know that we need to break those shackles and be very strong, be there for ourselves, be kind to ourselves, do not expect others to understand what you're going through because only you know what kind of pain you're going through, and set certain expectations from everyone around you in terms of cooperation so that you may understand that this is a disease and it is a full body disease which no one is experiencing other than you in your surroundings. So they have a limitation in terms of understanding what you're going through, for which you need to be mentally strong. Yes, you need the support of the mental health care that you need. You need the counseling, the therapy. You need to also have other support systems for coping with pain. So when it comes to nutrition, the anti-inflammatory diet is very, very beneficial from my own personal experience. There are certain supplements, for example, the omega-3 fish oil supplementation, which really works like a magic pill in the nutrition world for endometriosis because it's highly anti-inflammatory. There are superfoods, there are herbs, there are supplements that help in reducing inflammation, which directly affects pain in the body. So this is a little short presentation and a very short speech because I want to sum it up. So I will go to the intrinsic factor. Intrinsic factor is very interesting because the power of the mind to influence physical health has long been known one way or the other, but now hard science is defining the connection in depth, shedding new light in our understanding of wellness and helping forge new strategies for achieving it. For endo sufferers, the implications are profound. Over time, as we all know, pain responses can sensitize the central nervous system, impairing the mechanisms that inhibit the pain response and energizing the mechanisms that activate it, right? So in short, the brain has a lot to answer for when it comes to the pain that afflicts our body, souls, and life. So it's fair to ask, can the brain disarm its own pain activation mechanisms and build up its pain inhibitor mechanisms, right? That's a very logical question to ask, that is it quite possible? So here's what I want to say. Mindfulness operates as a mechanism of pain management. It is the only hardware that comprises the parts of the brain that interpret notification and cause pain perception. That is the mechanism for activating the pain perception for curbing it. So I just want to talk to you about a study. The concept is evolving, all right? A study run by Fidel Zidane, PhD of Wake Forest School of Medicine, was run, and it brought together 76 individuals, none of whom had ever meditated or done any kind of mindful exercise before. All were measured for dispositional mindfulness, a determination of the baseline mindfulness levels that were natural to them. To cut short, they were scanned, and The study participants then underwent functional magnetic resonance imaging, during which they received heat stimulation at 120 degrees Fahrenheit, pretty painful, right? Which of course was the idea. The scan showed that participants who had scored higher on dispositional mindfulness levels experienced less pain. So to sum it up, mindfulness, as simple as it sounds and as easily as it is ignored, shows profound effects on the pain mechanisms in the body, and it reduces the sensitizations of the central nervous system in women with endometriosis bodies. And that is irrespective of what stage of endometriosis you are on, whether you are an adolescent, where you're in premenopausal, you are at reproductive years. This is something that is cost effective. You don't have to pay anything for it. You can start right away on some simple practices. Mindfulness is one of those. Other very, very scientifically proven studies have shown that physical therapy, pelvic floor therapy, visceral therapy, which I myself have done and I'm still going on with, these have profound effects on things like gut dysbiosis, kind of all hormonal dysregulations, the HPA axis dysregulation. Visceral therapy helps to overcome that as well. So this is something that can be used in a multidisciplinary approach to treat conditions like endometriosis, and it can be used as alternative treatments that go hand in hand with the medical approach. So that's all I have to say for today. Thank you very much for having me.
Thank you, Radhika. And it reminds me of our old sages who could overcome all kinds of physical, problems, or could actually put themselves into a state where they could not feel any pain or hunger or any of those things. And it was all deep meditation that helped them to do this. So very interesting concept. And I think more of us should learn from you, because pain is sort of an integral part of everybody's life these days, considering the kind of lifestyles we have, and the commute conditions, as well as the office conditions where you sit for hours in front of a laptop. So many of us suffer from chronic pain, and I'm sure some of the techniques that you're mentioning would help, apart from the physical activity part of it as well. I am very interested about one thing. I've heard so much about this anti-inflammatory diet and all kinds of combinations of anti-inflammatory diet, including the do's and don'ts, and a long list of what you should not be eating. So how useful is it really, and is it really a science?
Yes, it is a science. So there are foods that are anti-inflammatory, and then there are foods that are pro-inflammatory, which increase inflammation. So first of all, we need to eliminate the pro-inflammatory foods, which in endometriosis patients' case is gluten, sugar, dairy, all kinds of processed foods, all kinds of processed meats, dairy, eggs, and things like that, alcohol, caffeine. Then we have nicotine. These are pro-inflammatory foods. So first we need to eliminate those from the diet. And then there is something called the elimination diet, because endometriosis is not a one-size-fits-all disease. All have different sensitizations, all have different bodily issues going on. So the elimination diet really helps when it comes to eliminating foods, because what may work for one woman with endo may not work for another woman, and what food one woman may need to avoid may not necessarily apply to another woman. So why give up on everything? So in order to find that, and in order to estimate what foods you need to follow and what you need to eat in order to heal, the elimination diet is the way to go. It is even more effective than allergy panels and all those IgE and IgG testings that normally the American Institutes of Medicine do not really recognize anymore. So the elimination diet is what will help you recognize what foods you should be eating and what foods you should not be eating. And once we determine that, it's more important to focus, which I say to all the endometriosis clients that I come across, please focus on the foods that you must eat in order to heal and overcome the inflammation and pain symptoms, rather than focusing all your attention on the foods that you should not be eating. How can we incorporate those foods? How can we incorporate the essential amounts of protein, the essential amounts of healthy fats in our body, and the essential amounts of complex carbohydrates to overcome any gut issues, to build the gut flora, which is actually very, very helpful in healing endometriosis on a holistic approach.
So would probiotics help?
Yes, the gold standard is to have probiotics. But if you want to go in depth, there are certain tests. There are certain gut, like the SIBO test, for example. There are vaginal bacterial tests that which is not really recognized that much yet, but that is the way to go. However, if that is something that a patient with endometriosis is not very comfortable with, I would recommend investing in high quality probiotics.
Yeah, there's a growing body of evidence that links your physical status to your nutrition and your mental status. I mean, the nutrition is the central part, which sort of plays between your mental and your physical status. If you're not physically well, you're mentally not well, and vice versa. If you're not mentally well, you feel physically sick. And then the nutrition is the binding factor. So very insightful. And I think we need to have just one special session with you on this whole thing about how mindfulness and nutrition can play a big role, because a lot of autoimmune conditions are being seen today in very young people. And these autoimmune conditions respond very well to anti-inflammatory diets.
Yes.
And even chronic conditions like, say, stroke, etc. Once you have stroke, you need to change your diet. And a lot of people are now recommending. But then again, it's a specialty that is not recognized very well. And not every nutritionist is trained on it. So we can have a special session with you on that. Thank you so much, Radhika, for being there.
My
And
pleasure.
for the panelists who are online, if you could turn on your cameras, we would take a little small picture. Dr. Chaubal, are you there?
Dr. Meenakshi, could you please, switch on your camera for a moment if you are there?
I think you can take a picture like this. We can see her name.
Yes, ma'am. Done. Thank you so much.
Thank you, everyone. Thank you to all the panelists, and we will send you notes to this meeting and some steps forward. Thank you so much for joining us today. Thank you. Have a great evening. Thank you.